headaches. That is our topic for our presentation. What we are going to do is go through our presentation, and just to tell you a little bit about myself, my name is Jody Gutkin. I am a physical therapist, and I've been practicing for 25 years. I can't believe that, and have enjoyed working in many different settings and with many different disciplines. So I enjoy pulling different examples into my presentations. I have practiced in neuro rehab. That's a large area of practice for me, with individuals following amputations, head injury, spinal cord injury, stroke. I've also worked in the pediatric setting along the continuum of care, from the neonatal intensive care to general acute care, as well as outpatient and home care, and then also in the school system with integrated schools, as well as developing IEPs for children. Rounding out my experience, I've also worked in the outpatient setting with our orthopedic population. That ties into today's presentation. And I am also an educator. I hold a master's degree in education, specializing in distance learning, so it lends itself well to our method of instruction today. And I've been teaching in a physical therapist assistant program for many years and enjoy that also. So I look forward to discussing our topic with you today. And let me go over a little bit about what we're going to cover, and then I'll review the specific schedule of the day so that you know what you need to do during the presentation. Our course today is looking at headaches, which hopefully many of you did not already come into this with as you're trying to finish up your licensure if you're in the state of Florida. Our course is going to look at the different classifications of headache, comparing the clinical presentation to the medical management, and how we can best manage our patients in terms of this, identifying the specific type of headache they have so that it can be treated appropriately. Also, I wanted to bring up that there are, with looking at this course, that there are many different bodies of research out there that you may be treating patients where a headache is their primary diagnosis, or possibly it's a secondary diagnosis that they have. Maybe you're treating that patient for their ankle sprain, or they have had a head injury in a sport, and now you're treating that patient for rehab. So there's many different ways that we are looking at individuals who have headaches as we work our way through today's presentation. As I mentioned, our goals are going to be understand the physiology of headaches, the medical and pharmacological management, and then we'll look at some specific types of headaches in our pediatric population and how that presents a little bit differently than in the adult population. As with any course that you attend, when you go back into the clinic to apply this information, you are going to do that in accordance with your federal, state, and professional regulations to utilize the interventions appropriately and the ideas that we discuss. Here's our schedule for today, and we will, in our first hour, look at tension and migraine type of headaches. In our second hour, we will go a little more into pharmacological and medical management. And then in our last hour, we'll look at some complementary therapy that can be utilized to manage migraines, as well as our pediatric headache diagnoses. So as I mentioned, the emphasis of our course today is looking at headaches, which present in many different ways. Headaches in and of themselves are a major public health problem. They are associated with a significant amount of not only personal suffering and disability, but it also contributes to a significant societal expense because it impacts work and interaction for individuals. If we consider looking at headache impact in the United States, in 2013, the American Headache Society, they analyzed national surveys, epidemiologic data, and they looked to try and see, well, what is the real impact of headache? How prevalent is it? And what they found is, looking at studies that had between 15 1,000 and 100,000 participants, they found really remarkably consistent data saying that cephalgia, which is basically the medical terminology for headache, they're finding that it is a significant cause of emergency room visits. For outpatient visits, it's peaking very high. It's one of the top 20 reasons that they're seeing for visits. And another trend that they're seeing among all these different studies is the incidence is significantly greater in females than males. It's 3 to 1. And all the ladies here, right, we're like, yes, we are under much more stress. But we'll look at maybe there are some other factors contributing to that also. In 2009, they actually said that there were 12 million office visits for the primary complaint of headache. So that is significant. We are seeing these patients in our clinics, whether headache is their primary diagnosis or maybe a comorbidity that they have. And this is something that you want to consider on your intake for your patients, or when you ask about other diagnoses and past medical history, is headache something that you have a place for and that you find out? Because it is extremely impacting for the individual. Even if you are treating them, let's say for that hand fracture or that total knee replacement, if they have headaches, being in the situation of the stress of a new diagnosis or other stressful life events could increase their headache disorder that may impact their overall rehab for you, because we're treating the entire person. So as we work through today, you'll have some different ideas of pieces of information that you may glean from your patients that will give you more insight into their headaches and how it may be impacting their rehab with you. I began to think, as I was looking at the different research, well, is this just something in the United States that we're seeing? Or is there a trend across the globe? Is it our lifestyle here that's contributing to this huge incidence of headaches? And the reality is that we do see a difference in the incidence as we look across the globe. In the United States, the prevalence of headaches is about 17 to 23% of the population are going to experience a headache. And as we look across Europe, Eurasia, into the globe, we're going to see that in Spain, there's a lower incidence than Germany. It increases. And by the time we get over to China, their reporting of headaches is almost on par with the frequency that we're seeing in the United States. And this is very interesting to see, because what they're finding in the research is that individuals, that this prevalence in females, that's being seen everywhere. What we found in many areas is that individuals who have a lower educational level and a lower income level, they actually have a greater incidence of headaches. It tends to be inversely proportional. And the studies didn't give a specific reason for that, but they surmised that maybe it's the stress factor, it's the physical exertion factors that may play a role for those individuals. Also, they're finding that looking at, for example, China, that they hypothesized in the research that the greater influence in female to male in that culture, and the fact that in general headaches is on the rise, could be a cultural influence, that males traditionally in that culture are to just tolerate pain and deal with it, so maybe they're not seeking medical attention. And then we're also seeing in that region that our female patients are out in the workforce more, that they are working but still expected from a cultural perspective to manage the home, so now their stress level has increased and their commitments have increased. So maybe that psychological piece is playing a greater role. The way that the different types of headaches are classified is utilizing the International Classification Headaches from the International Headache Society. It's an organization that puts out a massive document. They recently updated it in 2013. And I can say that I have read a substantial portion of it, and I'm translating it for you today. It really is the basis of a lot of the information that I am presenting. It compiles all of the over 300 types of headaches and subcategories that exist. And it is going to go through and explain the etiology, the management, the practice patterns. It's a wonderful document with a lot of great information that none of you probably have time to read because you're busy out treating patients. So my goal in developing the course is to pull all the different research and information that's out there and translate it for you in a brief, understandable format. Any research studies that I utilize to create my presentations are all referenced at the end of the PowerPoint slides. I tend to utilize resources that are available out there for free on the internet. So if there was something you wanted to read yourself or go a little more deeply into, that information is available to you also. When we go through today, we'll use this international classification as our basis to establish and analyze the different types of headaches. And three of the broad classifications that they start with are cranial neuralgias, secondary headache, and primary headache. Cranial neuralgias are a specific type of headache that is going to result from nerve irritation of either the optic or the trigeminal nerve, and it results in specific facial pain. That's a different diagnosis than what we're discussing today. So is secondary headache. Secondary headache is when an individual has an underlying diagnosis, and the symptom of that diagnosis is the fact that they have a headache. So for example, if your patient has a sinus disorder, they have sinusitis, and it places pressure and creates a headache, that's a secondary headache. If someone has an infectious disease with a high fever that leads to a headache, that would be a secondary type of headache, as well as vascular disorders. There's some type of tumor, trauma. With secondary headaches, we see that the individual has some other primary diagnosis that can very objectively be established, and the headache is the symptom of that. Our other cohort in red here, where we're going to really focus, are our individuals who have primary headaches. And these are individuals where all the diagnostic testing has not found a specific cause for their headache, that the headache in and of itself is their main primary diagnosis. And the lab tests rule out any other underlying occult disease, as do the other diagnostic imaging. So they settle into this category of having a primary headache. And then the four types of primary headaches that we'll look at are tension, migraine, cluster, and overuse. That's where we're going to really focus and break down those today. Even though for primary headaches, the idea is that any other pathology has already been ruled out. Whenever your patient is presenting with headaches, just like with any other diagnosis, we have to be conscientious of our red flags that can alert us to the fact that there is another underlying condition that needs to be analyzed. And the red flags are things we're going to monitor our patients for that may help us to identify if there is an underlying cause, another pathology that is leading to the headache. Thunderclap headache is one of them that you may not have heard of, and this is something to be aware of. That if your patient is complaining of a very dramatic, significant headache, it's the worst headache they've ever felt, it comes on very abruptly and explosively, maybe peaking in about 60 seconds, reaching its intensity, and then it starts to fade, This may be indicative of either a hemorrhage or an aneurysm. This is considered a medical emergency if your patient has that thunderclap type of headache. So you want to treat it that way. It could also be maybe a clot in the ventricular system in the brain that's leading to that severe type of headache for the individual. So we want to be cautious of that and monitor our patients. If your patient is having a headache that is triggered by either a cough or a sneeze or Valsalva, where they have increased, they're holding their breath and they have increased intra-abdominal pressure, and that is leading to increase in their headache. This cues us in again that there is something circulatory that is being compromised. So you're going to correlate that to other findings of possibly dizziness, blood pressure changes, etc. And that might let you know that this patient is having possibly a cardiac event, or they have another circulatory change, possibly hydrocephalus, something else that is contributing. It's not just a migraine or a tension headache, so you'll want to seek out for that individual other medical management. We're also going to see if our patient is reporting that their headache is persistent in the morning, combining it with nausea, or they're having position changes increase their headache. These are, again, indications that there might be a change in the intracranial pressure for the patient and indicative of either a subarachnoid hemorrhage, maybe venous thrombosis, arterial dissection. The list goes on, and they're all diagnoses that are beyond our scope to be aware of. That patient may need CT, MRI, MRA, to look at the vascular supply. So we need to be aware, once we go through our explanation today, of how the primary headaches present. If it really is not specifically fitting into those descriptors, and you're seeing some of these other red flags, that's going to let you know that your patient should be referred for additional medical management. And again, and again, this may be the patient you're treating them for their headache, or you may be treating them for another diagnosis and it just comes out in conversation because our patients see us, they talk to us, they explain things, and we start to hear from them the frequency, the duration, the sensations they're experiencing. We learn a lot about what's going on, even if it's not the diagnosis we're treating them for. So we may be able to offer some insight if they need to seek out some additional medical diagnosis or contact with their physician to manage their symptoms. When we look at understanding the different types of headaches, we are going to look very specifically at the way that it presents, because they all are very different, that help us understand what's going on physiologically. And those of you that have taken my courses before know that I love the physiology. I think if we understand what's going on, it allows us to see and make sense of the symptoms and the progressions that we're seeing in our patient to aid our clinical decisions. When we go through our discussions today, we're going to look at the physiology of tension, migraine headache with and without aura. Aura is where the individual has a specific set of different neurological symptoms that they experience before they actually have that headache pain. We'll talk about cluster headaches as well as medication overuse headaches. The data suggests that migraine and tension type headache are most common, and that 80% of the population at some point in their life will experience one of these headaches. My hope is that it is not triggered for you today during my presentation. Hopefully we keep you going and do not trigger any pathology. This is significant for individuals in terms of 4% of the population having a chronic daily headache, which is going to impact their work, their family lives. So that has a societal impact. And for many of those individuals, there's really no objective reason for their headache. They can't put their finger on it. What we'll look at is teasing out these different types of headaches and what's really going on for the patient so we can help manage it. Tension type headache is our general population incidence. Around, they say 30 to 78% of the population at some point in their life is definitely going to experience this tension headache. Previously, it's been called a stress type of headache. Again, it's seen more commonly in females than males, and this is the headache that we're more likely to see patients coming into our clinics where we're treating them for this. Because it does have a little bit of a musculoskeletal component to it. So these are the ones that we might have a greater impact in managing it and treating directly with our manual interventions. It is important for you to note that this is different than a cervicogenic headache. We will discuss those later on. Cervicogenic headache has a very specific etiology compared to a tension type of headache. Tension type headache, when someone presents with this diagnosis, they are going to be complaining of a very specific pain pattern. The pain pattern for our tension headache is going to originate in the posterior cervical region, just kind of inferior to the occiput. And then oftentimes it spreads across the head to the top and front of the eyes. And if we think back to our anatomy, it makes sense in that our frontalis muscle that wrinkles our forehead actually has a thick tendinous band that connects to our occipital muscle in the back that is located in that region. So the individuals that have this tension type headache, they tend to say sometimes like it's a cap squeezing their head. They're going to have possibly a pulsing sensation. The key here is that tension headaches are bilateral. So if someone is experiencing bilateral discomfort in this region, that this is going to kind of give you a little clue that it is more of a tension type headache. And if it does hit in that posterior cervical region, and it kind of comes up on top of the eyes, above the eyebrow. It's not behind the eye, it's not in the eye, it's above the eye. So it truly feels kind of like that cap squeezing the head is often how the individual is going to report it. With this type of headache, the individual's activity level, they can still function. They can get up. They can walk around. They may not feel fabulous because of the headache, but they're physically able to participate to some degree in their activities. These are not individuals who are experiencing nausea, vomiting, anything systemic. It truly is, the pain is isolated to the head region. Some of the triggers for this type of headache might be related to poor posture and ergonomics, leaning in an inappropriate posture. And this is generally speaking where if I was in a lecture room and I could see all of you, everyone, right, suddenly is starting to correct their posture as I talk about it. We also see fatigue, stress as triggers for this tension type of headache. There are many different theories as to why it develops. Previously, this was the type of headache where people might say, "Oh yeah, right, you have a headache, so you can't come to work, or you can't, go do whatever you need to do." It was previously thought to be truly psychosomatic, which is not the case. There really is now being found pain mechanisms that exist that trigger this type of headache, that there is a physiologic cause of this headache where we have an opportunity to impact and improve this for the individuals. In addition to the physical component, they are saying that there still is a psychological piece to it, but it's not the only reason someone develops a tension type of headache. What they're seeing in the research from the tension type of headache is the individual may have arthritis in their cervical spine. They may have poor posture and ergonomics. We may see, people down on their cell phones or at their computer screens, where the individual is developing a lot of muscular contraction in that cervical region. And because of that tightness in the neck and that suboccipital region, they're going to complain of pain when they do move that head. So that, again, is going to typically be bilateral, and it reaffirms that that individual may have a tension type of headache. Based on the population that you're working with, you do want to distinguish this cervical discomfort and tension headache pain from nuchal rigidity, where when you flex the individual's head passively, you're going to have a pulling on the meninges, and that can increase pain, which is indicative of a meningitis potentially. So based on the population that you're working with, please be cautious to distinguish your tension headache from your potential nuchal rigidity as a sign of another underlying condition that needs immediate medical attention. What happens with tension headaches, they're finding that over time, because the individual is holding so much tension in the fascia and the muscles in their region, that it induces what we call central sensitization. And those of you who manage chronic pain patients, this may be familiar terminology. Central sensitization is the idea that there is prolonged nociceptive pain input that is coming in to the brain from the peripheral region. So from those receptors in the cervical spine, we are seeing that the spinal nerves on the dorsal horn, all this input is coming in, this pain input, and that is being transmitted to the trigeminal nuclei in the brain and up for processing, that they're finding, because there's so much constant input that from those peripheral mechanisms, that it's causing a dysregulation, where the brain becomes now hypersensitive to these pain inputs, and it takes less input to evoke a higher pain response. So that's the centralization pain. They have like a increased hypersensitivity to pain, so then it takes less activity, less awkward posture, less stress to evoke that significantly high pain response from the brain. So they're finding that this poor regulation of those peripheral mechanisms, that the myofascia might be a culprit in contributing to this input, and it leads to a vicious cycle of pain for these individuals that needs to be addressed. The other theory that is a little different from kind of that physiologic descriptor that we just went through is that there is a psychosocial component, that there's a psychological piece to the development of these tension type of headaches. There are several different studies that have looked at this, and I want you to consider your patients who have other chronic pain conditions who are presenting with headaches, that they may have a condition where a headache may be a symptom, or maybe they've developed a primary headache disorder of tension headache because of their chronic pain condition of fibromyalgia, or if they have multiple sclerosis or other pathologies. What happens is this theory of tension type headache says that it actually starts in the psyche, the origin of the pain. And they're saying that possibly it's related to the hippocampus, that we're seeing some atrophy due to chronic stress. And then because of this, we're also seeing an alteration in the cortisol levels. And when they followed patients who had tension headaches over the years, they did validate these altered cortisol levels, which are responsible for managing our stress and our blood sugar and our fat metabolism and all of these different aspects, and that when we have an alteration there, it can trigger this pain pattern that leads to the headache. That you see more of a relationship in individuals with tension headache between fatigue, stress, anxiety, and their presentation of the headache. And so the theory is that the emotional stress has led to a change in the physiology of the brain that's contributing to the pain pattern that they're experiencing. So it's not just in the person's head, there really is a physiologic change, even though it may have initially started from an emotional or social stress or conflict of some type. And as OTs, many of you may be a little more involved in assessing that for your patient. And the medical management then is a little more multifaceted. We're going to see, yes, the pharmacological piece that we'll look at what specific medications are utilized, but we're also seeing that for these individuals, in addition to maybe taking non-steroidal anti-inflammatories, that we need to be aware of this psychological piece where they may need referral back to other resources to look at that component for them. We want to be objective in what we're assessing for our patients, so we're going to go through our assessment of those musculoskeletal components, looking at increasing cervical mobility, increasing scapular stabilization, so there's a good base for that cervical region to be stabilized. See what actions are exacerbating or stressing the cervical structures. Do they need an ergonomic assessment in their office? How are they driving? What's their sleeping position? So you're going to look at all different aspects from a physical standpoint to address it in almost of an orthopedic sense. And then you're going to have your secondary consideration that there may be that psychological component where we're going to teach our patient, if it's not beyond our scope, some other skills and management when we get into our second hour of the course. This tension type of headache, remember, if we go back to the beginning of what it feels like, because it can get confusing distinguishing these, The tension type of headache is going to feel like that cap, like someone squeezing the head. It's going to be posterior cervical pain and may come over to be more frontal forehead pain also, and it's going to be bilateral pulsing tension type of squeezing for the individual, which is different than our migraine pattern of pain. This is going to feel different for our patient. Migraine is another highly prevalent type of headache. This is ranked as one of the third most prevalent reasons of disability for certain populations of individuals, that they say there's up to 28 million individuals suffering with migraine. So this is pretty significant impact that, again, we're seeing these patients. And migraine can present in two different ways. Someone can have a migraine, which is the pain pattern that we'll discuss, that emerges. And then some individuals, before that, they have an aura. They have other sensory changes that occur that let them know that that pain is going to be coming before it actually arrives. So they are considering that also individuals who are adults with migraine, that there are childhood precursors that are evidenced earlier in life, which might be our opportunity, if we can catch those individuals sooner, to teach them coping skills and about their triggers and some different strategies, so that into adulthood, their migraines are better managed. They tend to see that children who present with significant motion sickness, vertigo, sleepwalking, some other different migraine variants, that they go on to be adults that have migraines. So those of you working with pediatrics, that might be an opportunity to intervene early and teach some strategies to help manage later in life those migraines. Migraines are very uncomfortable, to say the least, for individuals who are experiencing them. The migraine itself, when we talk about migraine without aura, we're saying that the individual just arrives at the point where they have this very debilitating pain in their head. Migraine pain is unilateral, tends to be in the anterior portion of the head. It's either going to be one side or the other. It tends to be retroorbital, so it says it's behind the eye. And I can tell you, I personally experience migraines. I have since I was 8 years old, so I'll throw in myself as a very specific descriptor throughout the course. I know for me, it just feels like someone is behind my eye just stabbing at it. It's pulsing, it's throbbing. And that's when the person gets to the point of having the actual migraine pain. In addition to the pain pattern unilaterally that the individual is experiencing, they are going to have other types of central nervous system symptoms. While they're having that pain, they are going to have sensitivity to light. They are going to have such as photophobia, phonophobia, sensitivity to noise. Some individuals have sensitivity to specific spells, osmophobia, where these individuals, it is physically, systemically impacting them. They are actually ill, and if you've ever seen someone with a migraine, individuals say, I can tell you by this point in my life, my parents can look at me, and even if I think I'm faking it great, they're like, you have a migraine right now, don't you? I'm like, nope, I'm good. And they're like, they can see it. Individuals who are suffering from a migraine during their migraine attack, so to speak, they look physically ill because their body, so many different systems are being influenced, that any type of physical activity is going to be hindered. Debilitating is a word that many individuals with migraine tend to utilize. And what we find with migraines is that there really is a neurobiologic cause, that there are specific triggers that can be caught earlier on in order to hopefully intervene before the individual gets to the point of this very debilitating condition that can last for 4 hours up to days for the individual. And then the attacks of migraine can be acute only less than 15 days a month, or they can kind of roll right into each other, the attacks, greater than 15 days a month for chronic sufferers. We said that migraine pain is when the individual actually is having the pain unilaterally, retroorbitably or temporally, and then they're concurrent with that, they're going to have the symptoms of nausea, vomiting, light sensitivity, and they feel debilitated and physically ill. In addition to that, individuals may have a migraine aura, and they estimate that about a third of the people who have migraines do have an aura that presents before it. And what this means is there'll be a specific set of neurologic symptoms to that individual that are going to happen before they get to that point of their pain. And that's what's really important here. It can be usually within the hour or more leading up to it. And each symptom that the individual experiences kind of builds and leads to the next one. And it's very curious when you see it. So they don't have pain yet, but the individual will start to have, usually unilaterally, fully reversible symptoms. Visual disturbance is the most common that someone may experience. They don't have to experience all these. It'll be different for everybody. They say zigzags or light flashing, something like that in many patients. They say about 90% of people it's visual. For others, it may be more somatosensory. Maybe they have pins and needles in different areas. It may progress to some motor weakness or vestibular type of symptoms. I'll tell you my pattern. And what happens with for the individual is each symptom will last, and then it kind of may overlap with the next symptom. And the first symptom relieves itself when the next symptom adds on. So for me, my pattern is I will start to have a little kind of numbness and tingling near my TMJ. I constantly want to move my mouth and say, am I feeling that? And that numbness and tingling will progress across my cheek to my tongue. And as it continues to progress, then it will move into some motor weakness of the facial area, some dysarthria. And then if it continues to progress, it will go down to upper extremity motor loss, lower extremity motor loss, and a progression from there into vertigo and lock me in my bedroom. I want to shut out the world. But what happens with individuals when they learn their aura, and they often have to journal to see it, is it's a blessing and a curse. It's, yes, you know your pattern, and that is so important because for individuals with migraine, the sooner you step in and intervene, you can halt the progression. I use my powers for evil, so to speak, and I say, you know what, I feel that migraine coming on. I know I have 45 minutes before I have to lock myself in the room, so I may not be the best at taking care of myself. I'll squeeze in whatever life things have to happen and deal with the consequences. Not recommending that for anyone. So I use myself as an example. Don't do what I do. Really, individuals should identify their aura. That can take about 72 hours, and know that each of these symptoms completely resolves for the individual. That they are going to evolve, persist, and then mitigate each of these neurological symptoms. What happens for some individuals, before they even have this aura, is a premonitory phase. And this is not very well known. It can happen in hours or even days before the aura, or before the individual maybe who doesn't have an aura actually gets to that point of headache pain. They may have a premonitory phase. And this means that they have an odd compilation of symptoms. Again, that's a little bit different for everyone. But if they tune into them and start to see the pattern, it lets them know that something is going to happen. It means that the neurological event is getting ready to begin, so we can intervene. And I'll tell you, mine, I found, is it's the yawning and the neck stiffness. That I can be at the gym, in spin class, on the bike, yawning, almost falling asleep. It's very embarrassing. So I use it as an excuse not to go. And I will have perfect ergonomics on the bike. I adjust everything, yet the neck stiffness is absurd. And then I found that as I tracked this, that 2 days later, my aura symptoms are starting, and then I can go into my migraine. So for me, and maybe for some of your patients, again, look at chronic pain patients, if they can look at other symptoms they may have, to empower them to not feel so helpless that all of this is just happening, that if you can find the premonitory phase for the patient and figure out what those symptoms are that may be hours or days ahead, they can intervene then and make the changes to manage it. So they don't get to the aura where they're accumulating these other odd neurological symptoms that resolve. Then they get to the point of actually having that debilitating head pain and all of the nausea, vomiting, light sensitivity, etc. Following all this, as they've tracked individuals who have migraine, they've actually found that there's a recovery phase. And during the recovery phase, the individuals, some research calls it a resolution phase, that the pain has gone, the neurologic symptoms have subsided, but they tend to see either hyperactivity or depressed activity for the individual, that they may have odd food cravings and some other symptoms during their recovery. If you add all this up, an individual who is in this pattern, this is a significant chunk of their life. The more we can do to intervene and recognize the triggers for them that start this whole process, the better the opportunity to make an impact for them. The key here is to recognize and distinguish migraine from other pathology. Like we said, we're distinguishing migraine from tension headache. We're looking for our red flags of our thunderclap or other underlying diagnosis. You also really need to pay attention that you're distinguishing a benign migraine aura from a TIA, for example. Because of course I'm diagnosing myself as I'm going through all my symptoms, right? So an individual who's experiencing aura, think of it as they're acquiring new symptoms. So I see zigzag lines. Now, after that's subsiding, now I'm starting to feel numbness and tingling. And as that's resolving, now maybe the individual is getting dizzy another, hour later. And you're acquiring something new and each is resolving. Versus a TIA, they're losing function. So the individual with the TIA, concurrently, they are going to have the dysarthria, the difficulty speaking, the motor weakness, the sensory changes. That's one way you can distinguish this in your populations. So from aura, where it's progressive with each resolving, and they're obtaining a new symptom, to a TIA where it's concurrent and they're losing function as they go along. Something to be aware of. Pay attention in your patients who have maybe a head injury, or if they've had cervical, brain cancer, spine, head and neck cancer, where they have a seizure disorder. You need to distinguish migraine aura from their seizure presentation for the individual so that we do intervene appropriately. If it is determined that they're experiencing migraine, we know that there are triggers for this whole process for the individual, that missed meals, certain foods, hormone fluctuations, that this combination of events that's a little bit different for everyone creates an environment where the symptoms tend to develop. So these different life factor choices, lifestyle choices, or the physiologic environment that it creates sets the stage for the different physiologic impact of the migraine that we're going to look at. Food triggers are always a big discussion with migraine, and they have found certain foods with tyramine in it that does tend to trigger the migraine. This is a monoamine compound that is found in certain foods which are produced with aging or fermenting. So you're seeing your cheese, your certain types of wine. For some individuals, it is the monosodium glutamate or different preservatives that trigger them. And the thought is with all of these that it causes some type of hyperexcitability of the pain metric in the brain, and it sets the stage for the migraine to occur. They suggest that if someone is trying to determine if they do have a certain food that's a trigger for their migraine, that they need to try about a 3-month trial of removing that from their diet to see if there is a positive benefit in alleviating their migraines. So they're thinking that somehow if they take that food out of their diet, the potential inflammation that it may have caused and alteration in the neurotransmitters in the brain can be alleviated, and then you can see if there's really an improvement in their pain pattern. That's what's setting the stage for the migraines to happen. What is actually happening when someone has a migraine, the research is not in total agreement on. I find it all very fascinating, though. So when I'm laying there in my attacks, which I should know better and to fend off, but I don't all the time, not successful, I think about physiologically what is happening. And there are many different theories out there. Many individuals with migraines misdiagnosed because those symptoms that we described of the unilateral retroorbital pain can be considered maybe a sinusitis. For individuals, it's important to recognize that migraines have those different phases we just talked about, and that when someone has the pain itself, they also have those other systemic symptoms. So that helps to distinguish it. Also distinguishing it from the tension headache, where they're not going to have the nausea, the light sensitivity, those effects happening. So that lets you know that is a little bit more of a tension headache. Biologically, what they're seeing when someone has a migraine is that it is a fluctuation in the brain chemicals and the activity in the brain. That what happens is called a cortical spreading depression. If we think about the brain, that normally we have neurologic impulses that are conducting to allow us to function. What happens when someone has a migraine is they are seeing the individual has this misfiring of the receptors in their brain, there's this wave of abnormal firing that goes through the brain. The neurons become exhausted and depleted and depolarized, and they are left the cells are left unable to function. That's why you see all these different symptoms occurring, and then they alleviate for the patient. That as that cortical spreading depression happens, we see all these different symptoms that tend to arise. Another theory that is out there is that it's related to glial inflammation. Our glia is going to insulate and surround our neurons in our brain. It doesn't actually conduct the impulses. It is going to just support them and insulate around them. And what they're thinking is that somehow these different triggers create an alteration in prostaglandins and then inflammation in that glia. Because of that, it is going to cause, again, an alteration and an irritation in the central nervous system. And particularly when this happens around the trigeminal nerve, it leads to our migraine that's occurring. I personally would love to have a PET scan done when I'm having one of my migraines to actually see the neurologic event that's happening. They have done research like this in different patients to really see what's happening, and that's how they have arrived at this cortical spreading depression, this electrical silence almost that happens after the cells are depleted that leads to the symptoms. They've also looked at some other potential culprits leading to the development of the migraines. Normally, what our hypothalamus should be functioning to do is maintain our homeostasis. It is going to serve as a central kind of regulator for the endocrine, parasympathetic, psyche, our nociceptive processing. And what happens is they are thinking that somehow the hypothalamus is misfunctioning and it is not processing the information appropriately, and that serves as a central trigger that leads to the migraine episode for the individual. They consider that this might play a role because lack of sleep or sleep disturbance can lead to migraine. And when we look at the alterations in the circadian rhythms, the cortisol, melatonin levels, that it leads to that connection that the hypothalamus might be a potential culprit, as well as the fact that there tend to be hormonal influences with estrogen levels and dysregulation in the hypothalamus that could be, again, contributing to the migraines. When they've looked at actual imaging studies for individuals who are experiencing migraine, they're finding that there is oligemia, which means a decrease in the microvasculature blood flow in the cortex of the brain. And they're finding that particularly in our trigeminal nuclei, there is a region that is very responsible for our pain processing of the nociception input. And they're finding that the neurovasculature is altered with decreased circulation in that specific area with microscopic ischemic events that is causing this spreading of the cortical depression. So they're finding that somehow there's a little association between vascular changes that are happening in the cerebral vasculature. For whatever reason in the individual, it's not automatically regulating itself appropriately, and that's contributing to the spread for the individual. What they've also found is looking a little more longitudinally at these individuals. If the thought is that there's an alteration in the vasculature, then the next logical concern would be long-term for these individuals. How does that influence their risk of stroke or hemorrhage? And what they found in some individuals is that there is a greater increase in hemorrhagic stroke for individuals who suffer from migraines because of this alteration in vasculature that's occurring. The other region that they were looking at the vascular supply of is the circle of Willis. And now we're really going back to anatomy and physiology from school. That circle of Willis is our network of vasculature from the brainstem that has the communications up to anastomose and supply the various arteries to the different regions of the brain. It really serves as our main communicating arterial system for the hindbrain as well as the forebrain. And what they found is that in some individuals with a malfunction in their circle of Willis, where it's not allowing appropriate cerebral perfusion and blood flow, that when there are increased metabolic demands that the person is under, it's unable to supply sufficient vasculature for the metabolic demands, and it leads then to that cortical spreading depression because those neurons are not receiving their supply appropriately. And it's just fascinating to think of all these different theories that they have out there. With this, they've extended their analysis for individuals, and they found that these individuals where the circle of Willis tends to be the culprit, they're at a greater risk of more of an ischemic stroke. They can't, definitively explain the mechanism, but they're seeing a greater incidence of stroke for these individuals. So as I'm on my way to the ER, I'm going, okay, if it's a hemorrhagic stroke, this is what intervention I want to ask for. If it's an ischemic stroke I'm having, this is what I want. Or maybe it's just my migraine, this is what I need to ask for. But I'm dysarthric, so I'm not actually asking for anything. So I make a little card for my family. So they know what questions to ask of the doctor. And it's not something to laugh at, but just to try and, keep everyone interested as you're watching me on TV. It really is very scary and debilitating for individuals as they're going through this. We know enough to just make ourselves crazy, but for our patients, they really truly have no idea what's going on. Not that we get into this discussion with them, but we get into the discussion in our management of how to help them see their pattern, how to let them see where can I step in and try to gain control back, or at least understand what's happening and see when resolution is going to occur. One study said that if you're working with cognitive behavioral therapy, which many occupational therapists may be doing, or as physical therapists, we could just be aware of this with our patients. Rather than having them worry about, oh my gosh, I'm going to be in bed the next 3 days, or what's going to happen, I can't take another day off work, you tell them to get through the next 5 minutes. And if they understand how their body reacts, they can maybe get a handle on things enough to minimize their triggers to halter progression, or at least empower them and put them in a better mental place to get through the next 5 minutes so that then they can handle the overall incident a little more easily. When they look at another theory of individuals have a specific type of migraine, it's the hemiplegic type, and that's actually what I described that I have. The hemiplegic migraine results in a motor loss, but then it resolves after. It's highly associated with brainstem symptoms of vertigo. So be aware of this for your patients if you're differentially diagnosing along with the physician. Specifically, hemiplegic aura, individuals with this, they tend to see a genetic predisposition. And there is a different physiology that they see in addition to what we've already discussed, that individuals, they believe that there is a genetic predisposition that alters the ion transport in the brain. and it impacts the various neurotransmitters, not allowing them to be transmitted and fire appropriately in the neurons, and that leads to the various symptoms that the individual experiences. One thought is that the calcium channels are involved, that the doors are not opening and closing appropriately for the calcium channels, so the neurotransmitters are not released appropriately, leading to the various symptoms. They've also looked at sodium channels as a culprit, as well as the sodium-potassium membrane proteins being altered, and the electrochemical gradients are altered in these individuals because remember, our ions have positive and negative charges, and that is what our depolarization of our nerves is based on. So if these channels are not functioning appropriately, the nerves are unable to generate and transmit their electrical signals, and that's what's leading to the migraines for those individuals. It is, again, a very specific type of headache, but in these individuals, the medical management may be a little bit different because of this potential genetic alteration in the ion transport there. So the medical management for anyone with a migraine is going to be multifaceted, that it's looking at pharmacological management as well as a behavioral piece to look at managing the potential stress trigger, and then lifestyle strategies to look at the other types of triggers. Muscular therapy is not really going to have a benefit for these patients because of everything we just discussed. It's more of a neurological event. So you're going to maybe see these patients in therapy, but your musculoskeletal techniques are not going to be your first basis of management for them. For many individuals with the migraine, it's going to abate with sleeping often. If the individual can just get to sleep, it may help alleviate some of their symptoms that they're having. Cluster headaches are our next type of headache. This is a very rare type of headache, but I just bring it up in case you are, it comes out in conversation with your patients that they do have this kind of peculiar type of headache. It's very rare. Only 1% of the population presents with it, and it tends to be more common in males between 40 and 50 years old. What happens is, these individuals are going to experience a very acute type of pain. It is going, oops, sorry, I misclicked there. Let me get it back. Where'd I go? Okay, sorry about that. So individuals with cluster headaches, they're going to experience this in like a bout. And what happens is they're going to have a very quick onset of this unilateral pain behind their eye or in their temporal region. So it sounds similar to migraine, but here's how it's different. These individuals also present with rhinorrhea, so a runny nose, lacrimation, tearing of the eye. They may be diaphoretic, where they have a little increased perspiration on their forehead. And these individuals are going to say that this pain is excruciating pain. It causes them to be very restless and agitated. And what they think is happening with these individuals, with all of these kind of autonomic type of symptoms, that it is a genetic predisposition, and the hypothalamus seems to be playing a role because it's not giving appropriate output to the trigeminal nerve, and the trigeminal nerve has very specific branches that go to the head, the eye, and the nasal structures, and that's why we're seeing these kind of central, almost sinus type infection symptoms for the patient, but it's because of that alteration, they think, in the parasympathetic flow that is triggering these symptoms along with the pain for the patient. Because this is very excruciating for the patients, it tends to be deemed a medical emergency where they're going to need medical management in order to alleviate the symptoms for them. Sometimes hyperbaric oxygen is actually utilized for those patients to help manage it. And it's another situation where they really need to look at their triggers in order to manage and avoid it appropriately. Looking at our fourth type of primary headache, these are our medication overuse headaches. This is something that you have to pay attention to in order to catch. They've previously been called rebound headaches, where an individual has either a tension headache or migraine headache, and they're taking so many different medications to manage it that now, because their body has become either dependent on the medications or desensitized or hypersensitized because of the medications, they have a whole new type of headache that's developing. What they are finding is that as we have patients with greater access to medications, you see the advertisements on TV. Over-the-counter medications are very readily accessible, that individuals may be falling into this medication overuse headache and not even realizing it. They are superimposed on top of the existing headache. And the way that an individual may notice it is they wake up in the morning and they immediately see that they have a headache already. The day hasn't even started yet. So that might be your first clue that it is a medication overuse type of headache, and that people who have taken medications for greater than 10 days in a row for over 3 months, so they have, a third of their month for over 3 months, they're taking different types of medications, they're putting themselves at greater risk for this overuse headache, and that might be where you're going to clue in and look for it for the individual. What happens is it's triggered, their primary headache is triggered from whatever their exacerbating factors are. So they take medications to try and manage it. But because maybe their lifestyle, all the factors haven't changed, that they're still not sleeping great, that they're having, a lot of stress still, and they continue to take the medications, well, now the body is in a cycle of becoming dependent on those medications, so they try to skip them a day, and the body reacts to that with a headache. So they have this new type of headache on top of their existing headache. And what they're finding is that individuals really need to detox, which is beyond our scope. It's something for them to work out with their physician, but something for us to be aware of and to support them through and refer back to the physician as necessary. They say that patients really need to stop the medications for at least 2 months, before they can see if their headaches revert back to their original pattern, meaning that it's no longer the medication overuse headache that, oh, right, this is just my tension headache or just my migraine, so I can resort to those other management strategies for it. Looking at these different types of headaches, they do all present very specifically. And at this point, you should have a little clearer picture of the different kinds and recognize that when we consider our medical management, that taking the time to identify the specific type of headaches that the individual has is going to lead us down the right path now for managing it appropriately. Because there is a significant burden. They estimate that it's about $14 billion annually is spent on headache management for individuals. And what's challenging for many of these individuals is there are no objective tests or findings. That there's not a piece of paper that they can, read an MRI or an X-ray and say, yes, this is why I have my headache. So journaling becomes important for them to start to see patterns in order to look for their symptoms, as well as empower the individuals so that they have a way to feel like they can tap into the management and be helpful. The research is interesting because they're finding that when researchers analyze the best way to manage different treatments and what should medications be accomplishing, it doesn't always match up with what patients' goals are. And we know as clinicians, we spend so much time with our patients trying to see what their goals are and have a good match because it has a positive outcome. Most of the research looking at the management of headaches is considering that if we can get the person pain-free in about 2 hours, we've had a great outcome. So that's what the medication companies are looking at and all the other different interventions. So someone did a study saying, well, what do patients really want? And someone who is suffering with a headache, 2 hours is an eternity. They say, you know what? I would really like to have pain relief in 30 minutes. And I would like to get back to functioning. I would like to be able to be involved in my life again and interacting. I want to be able to think. I want to be able to move. And I want to know how to prevent reoccurrence. This is what the patients are looking at. And I want to be able to know how to step in and intervene. So if you consider these different aspects, these are all areas where we can have a great impact on educating our patient and assisting them in these areas. And this would be in addition to the medical management that they're doing with their physician. The specific pharmacological management of headaches is looking at 2 categories of medications, either abortive medication or prophylactic medication. Abortive medication is going to be utilized when the individual already has these symptoms and they're trying to stop the progression. Prophylactic medication, individuals going to look at taking every day to just avoid the progression of symptoms in the first place. Many patients have what they call medication misadventures in trying to manage their headaches. They have too much medication, or they take it too early or too late and it's not effective. Maybe the diagnosis isn't right at the outset. Again, an opportunity for us to be the team with the physician, with the dietitian, with the other health professionals, particularly if these are chronic patients, to have the best possible outcomes for them. When the physician's prescribing medication for the tension type of headache, the tendency is usually to utilize an abortive medication where they're taking an over-the-counter analgesic or non-steroidal anti-inflammatory, ibuprofen, naproxen, something of that type, because with tension type headache, there is that musculoskeletal component, so it may be helpful in breaking into the pain cycle, in managing any inflammation that might be occurring. For some patients, because of that psychological component, there is sleep disruption and mood alterations, so the physician may prescribe antidepressants to try and manage it from that aspect. If that is the case, find out from your patient when that medication is started. If the medication is to try and manage their sleep disturbance, you tend to see that those medications cross the blood-brain barrier a little bit more quickly, so you'll see an improvement in their sleep, but then it'll take a little bit longer before you see an improvement in their headaches. It may take 3 weeks or more for the headache alteration and improvement to occur. So just be aware of that for the patient. Also monitor your patient if they're taking a lot of over-the-counter medications for other GI involvement. That could be indicative that they are taking too many of those medications. Epidural nerve blocks are utilized for some patients who have tension type headaches, and the physician may use that nerve block in a situation where they need to manage the symptoms until the medications kick in for the patient or your other interventions take effect. So they might choose to utilize an epidural for the nerve block for those patients. Sorry, not an epidural, in the cervical region specifically. For individuals with migraines, timing is key on their medications. It's very important to note that we have that premonitory phase, potentially that aura, then the migraine pain with symptoms, followed by the recovery phase. So there's lots of opportunities to intervene for the patients. And what they're finding for some patients, they may take what's called triptans. That may be your Imitrex, your Relpax. Other patients may take what they call an ergot derivatives. That's another category of medications. They're not taking your typical over-the-counter anti-inflammatory medications because we're not looking at inhibiting the prostaglandins. That isn't going to alleviate the symptoms. This is more of a central event for the individual. And what they're finding is that some of these medications may work because based on the circulatory status of the vessels at the time of the incident for the patient, that these medications will impact those small vessels, small, smooth blood vessels in order to alter their tone and help prevent the progression of the event for the patient. If someone's significantly limited where the abortive medications don't work or the individuals are unable to look at managing and stepping in at the appropriate time, then they may be looking at more of a prophylactic type of medication. And for individuals, these medications may be targeting the calcium channels or beta blockers if there is a sense that those ion electrochemical signals are being disrupted. For many individuals, it may be related to the sleep disturbance and the mood alterations. So those individuals may be taking antidepressants to try and manage their effects, maybe stabilize their serotonin levels as a method. So it's really going to depend for the patient. The physician will go through the different categories of medications to see what works best for the patient. Often the medications have a combination of maybe a narcotic, a caffeine, and an anti-inflammatory in them to try and tackle it from different aspects. The caffeine may actually help with the absorption of the medications. And then another aspect to consider with patients is that when they get to the point of the migraine pain, they may be vomiting at that time. So they're unable to ingest their medication and have it absorb into their system. All the more reason that it's important for them, if they're using abortive medications, to take it sooner, or some patients may actually need to be on antiemetics so that they can get their medication in if it's progressed too quickly, where they're unable to time it appropriately. When someone has their medication overuse type of headaches, it is necessary to combine the medication decrease with behavioral components for them to address the multiple aspects. And it's important for them to work with their physician to wean off the medications and detox from it, and know that their pain may initially increase, but it's because we're trying to get them back to their baseline headaches. We're trying to alleviate this new headache that has developed. So they need to get past those symptoms to get back to their baseline tension or migraine, so then you can be more effective in managing that specific component of the headache for them. And when we look at coordinating our management for the patient, that education in lifestyle as well as altering their behavioral interventions is important. For some patients, they may need more of an aggressive intervention in order to block their pain so that their other lifestyle and psychological management techniques can kick in to be effective. And in 2013, the American Headache Society came out with a standardized recommendation for the use of peripheral nerve blocks to manage patients with tension and migraine headache disorders. And what happens is the peripheral nerve block is going to achieve cutaneous analgesia and give benefits for maybe weeks or months for that individual, so that there is time for the other interventions to kick in and allow that person to return to their activity, to their function, to be more effective. When they perform the peripheral nerve blocks, they are looking at the specific dermatomes, and often they are going to be utilizing not only the occipital nerves, but also the supratrochlear nerve is a branch off of that trigeminal nerve, which plays a significant role in nociceptive modulation. And they will be injecting oftentimes lidocaine for these patients to try and alleviate the pain that they're having. And then they will have relief of their symptoms. What they found additionally for individuals who suffer specifically from migraines is that Botox has been approved by the FDA for the prophylactic management of migraines. This is for individuals who suffer from chronic migraine headaches, where they first noticed this because individuals who were receiving Botox for cosmetic reasons had a decrease in their headache complaints. Now, that can be explained many different ways. The quality of the research has been brought into question. One study I looked at pulled all the other research, and there were 315 studies looking at the use of Botox to manage migraines. And when they really looked at the methods section of the research, only 31 of them used randomized controlled trials. But there was enough research to say that for migraines, it looks like Botox may be beneficial. They theorize, though, that some of it may be a little bit of a placebo effect. So my goal is to figure out how to get Botox for my migraines in my frown lines and my wrinkles, and kind of double dip on my benefits. You know, they say with the placebo, does it tie into that, you know, you look better, you feel better kind of thing? Or is there truly a benefit from the Botox in terms of alleviating the migraine symptoms? Verdict is out, so it's a conversation for the patient to have with their physician. But one researcher took it a little bit further and said, you know what, if they're finding with Botox that they can alleviate certain trigger sites for migraines, well, why can't we just go in and surgically alter those trigger sites? Let's alleviate the nerve compression if that's what the problem is directly, and have a benefit long-term for these patients. They had a group of 100 volunteers who underwent half of them were control, half of them underwent the procedure, where they found specifically where the different migraine triggers were. For example, in one, they removed the corrugator muscle to relieve the pressure and the nerve irritation. And in following these individuals at 1 year out, those that had the surgical intervention had such a significant alleviation of their migraine symptoms that the control group ended up going in and having the procedure done. There was some validity then to the fact that there are these different, trigger points also that can be alleviated to help with the individuals by surgically changing the anatomy in the area. For them, eliminated the symptoms. Many different ways they're looking at managing migraines for individuals between medication as well as surgical interventions. Lifestyle changes tend to be an opportunity to impact individuals who have headaches. It's very easy to slay, sleep a lot, eat right, and chill out. Don't be so stressed. Except it's not that easy to accomplish that. So it's important for individuals to look at their specific triggers and be aware of how they can alleviate them. Lifestyle changes, specifically looking at increasing aerobic exercise. They have found that individuals who are participating in 30 minutes of aerobic activity 3 times a week, they were able to decrease the intensity of their headaches. Mixed results on whether it changes the frequency, how often they have their headaches, but it did help in decrease the intensity of those headaches. They're finding for about 20% of the people that the food triggers are what begin the cascade of effects that lead to the symptoms, particularly with caffeine being one of those aspects where it's a double-edged sword. Small amounts of caffeine, they may help alleviate the acute symptoms of a migraine, but if an individual is used to consuming high amounts of caffeine and then they stop it, that can trigger a migraine from the withdrawal. And then in general, just consuming too much for some people causes the migraine. So it really runs the gamut, and everybody's body responds differently. If you consider the fact that just related to migraines, we talked about 4 or 5 different theories of what's actually happening physiologically. So with the caffeine, the theories are out there. One is related to that the adenosine in our brain, that typically it is going to be binding in the brain. It's going to help with sleep and oxygen and have beneficial effects. And somehow that caffeine is going to bind differently to the receptors and alter the functioning. But I wasn't able to find a specific study that could concretely say what's the benefit or the negative side of caffeine. Generally speaking, the studies seem to say that there's an altered vascular supply in the brain when we consume different levels of caffeine, and that is what's contributing to some of the different changes that we're seeing. Again, the theories are out there that maybe a little bit of it helps, because it releases dopamine, so it stimulates the pleasure sensors also in the brain, and then that's a sense of well-being that alleviates stress. Honestly, the theories are all over there, and I really went into the research with an open mind and want to present to you the different options. The key is for individuals to pay attention to how their body responds to the caffeine in order to react appropriately. and modify either up or down their intake to see if it is functioning as a potential trigger for them related to their migraines. We were discussing the different types of management of headaches and the dietary aspect specifically. What they have found when we're looking at that holistic aspect of managing our patients, we have omegas in our diet. The omega fatty acids are the precursor to the different lipid mediators in our body, and they found that specifically omega-6s tend to lead to the development of increased pain perception. So they have pronoceptive effects. So as opposed to our omega-3 fatty acids, they have more anti-nociceptive effects, meaning the more we consume of those, the more beneficial in stimulating the different cell membranes and different structures in our body and brain that lead to decreased perception of pain. An individual who is more prone to migraines, they did a study to find that over a 12-week period, individuals who specifically changed their diet, they were able to decrease the incidence and frequency of their migraine and tension headaches, that the duration of the headaches was left, that they felt an improved quality of life. And when they actually checked the biological markers, they found that there were more anti-nociceptive markers in those individuals who consumed more omega-3s. The way that you can figure out what's an omega-3 versus an omega-6 is looking at the heart healthy diet that's put out by the American Heart Association. Omega-3s are going to be your fish, your salmon, your tuna, green leafy vegetables, spinach and kale, as well as walnuts and flaxseed. Yum, right? Very healthy. If you consider this population, that is beneficial not only to increase the omega-3s so that at the point of their life that they're in, we're managing their headaches. Look long term. We said that individuals with different types of migraines are at a greater risk of different types of stroke. So this heart healthy diet can help manage blood pressure, decrease triglycerides, so that's decreasing their overall headache risk. So stroke risk. So we look at modifiable and non-modifiable risk factors. This might be an opportunity for individuals to eat a healthier diet to help control their migraines and improve their future health. Considering musculoskeletal interventions specifically, individuals with tension headaches, they may be likely to benefit from ergonomic assessment, your typical musculoskeletal interventions of massage, postural training, particularly looking at cervical mobility, as well as scapular stability and postural alignment so that there's a stable base for that head to be controlled on. The idea being that you can look at controlling that central sensitization of the pain by decreasing the feedback mechanism, those peripheral sensory inputs that may be pulling on the fascia and aggravating that patient, causing the hypersensitivity. So for those tension headaches, you may be breaking into that central sensitization, and you may help also limit that somatization of pain. The other way that you can look at managing patients who have headaches is considering the relationship between the TMJ and the headaches. They've done some research to find that there's a connection between sleep bruxism, TMJ disorder, and migraine and tension headache. Sleep bruxism is grinding the teeth at night. That is actually considered a sleep movement disorder that is mediated by the central nervous system. And we know migraine is some alteration in the central nervous system. What they found is that individuals who grind their teeth, that they're having increased trauma to their TMJ joint, which gives more nociceptive or pain input into the brain, that because of all the grinding at night, the muscles of mastication, the masseter, the temporalis, that they're having increased excitability of those muscles from all that effort of the grinding, and that stimulates that trigeminal pain pathway that again contributes to the central sensitization of pain, the hyperexcitability of the pain receptors in the brain, so then it takes less input to give that over response that leads to the headache for the individual. So it might be something to consider working with the individual's dentist if there is a history of teeth grinding there, or maybe they don't know and that is contributing. Maybe you're going to teach them relaxation techniques or self-awareness techniques. Even those of you sitting here now, do you know how tightly you're clenching your mouth? I don't know. Maybe you teach that self-awareness, that proprioceptive awareness to relax. Maybe the individual is triggering into this pathway unbeknownst to them when they're awake, even when they're asleep. The other area that we consider when we look at the musculoskeletal aspect, individuals who present with cervicogenic headaches. Cervicogenic headaches are a separate category from what we've discussed up to this point. This is actually a specific type of headache that is now recognized as having its own etiology. These headaches are going to be individuals who present with moderate to severe neck pain. It tends not to be throbbing. And the thought is that because the individual has had upper cervical pathology, so usually there's some history of trauma to the upper cervical levels, that the individual has been compromised in their musculoskeletal system, and now again that connection between the meningeal layers in that upper cervical region and the brain are somehow pulling on the different tissue layers and creating pain inputs to the brain and the trigeminal nerve and those upper cervical segments, that the body confuses pain originating from the neck as physically being in the head. So it's almost like the headache, where the pain physically is in the head and the face, is the symptom, and the cause then is the dysfunction in the cervical spine. In terms of teasing this out with diagnosis, just in a very brief sense, as I mentioned, it is now recognized as its own category, specifically with an etiology of trauma to that region. They tend to see that the pain is not going to fluctuate from side to side, that it'll stay ipsilateral for the individual. And that if you do your sensitivity testing in the different cervical regions, that you will be able to specifically exacerbate their pain, as well as with neck movement or different postures. So it's fitting that musculoskeletal presentation for the individual. We're going to look at the consideration for the individual that with our interventions, we're being aware of the fact that those fibrous connections between the cervical musculature as well as the cervical dura mater, the ligamentum nuchae, the spinal dura mater, all of those different fascial connections can be pulling and again creating pain in the head. So we need to be aware of not only looking at the tightness of the musculature and joint dysfunction to address that you're going to look at restoring full range of motion, proprioceptive awareness, and stability in this whole upper region. They've actually found in testing of individuals with cervicogenic headaches that they tend to have decreased muscle endurance of their neck musculature. This is important to note in terms of your postural awareness, ergonomic assessment also for those individuals. that cervicogenic headache presents a little bit differently than what we've discussed up to this point, because there is that specific mechanism that has of trauma that has contributed, and you'll be able to specifically reproduce a level where there's injury that leads to this pain presentation. That leads us to some other interventions that we may utilize beyond our traditional techniques involving complementary therapies. We're going to look at effectiveness for these different types of interventions can be beneficial to manage not only the overexertion, but the stress for individuals with all different types of headaches. And in the research, they've looked at several different categories and types of complementary therapies and their benefit for different types of headaches. Individuals who are presenting with tension type of headaches because of that musculoskeletal as well as psychological component. Some of the interventions that have been effective are looking at progressive relaxation, guided imagery, as well as cognitive behavioral therapy to increase the individual's self-awareness, as well as allowing them to decrease their muscle tension and stress. So biofeedback can be helpful for them to realign and relax. Feldenkrais, which encourages a self-awareness of body movement and alignment, can be helpful, as well as yoga, Tai Chi, Qigong. Those are looking at not only improving a state of mental well-being and relaxation and composure, combining that with range of motion, flexibility, and alignment, so it's beneficial for that tension type headache, as well as craniosacral therapy for that musculoskeletal and, I should say, fascial component to restore some of the alignment and maybe relieve some tension on those structures that may be triggering that particular pain pattern for the patient. With migraine therapies, what they've seen as beneficial are interventions in terms of complementary therapy to help the individual recognize their aura, avoid their triggers, and halt the progression. One example that was used in a study was looking at biofeedback, where they had the individual use a thermal biofeedback, placing it on their forehead and having them and then on their finger, and having them consciously try to decrease the temperature in their forehead and increase the peripheral temperature in their finger to try and induce some relaxation for those individuals. They thought that by using a distant point as a vasodilator, that it somehow helped alter that circulatory status in the brain to prevent the progression. Behavioral therapy for individuals is looking at managing their stress, increasing their self-awareness, and craniosacral therapy is something that has been proposed in order to give some longer-term benefits in terms of altering the autonomic nervous system response to the migraine to decrease the frequency and intensity of them. Generally speaking, with both migraine and tension headaches, they're seeing that a combination of biofeedback, yoga, behavioral management to promote self-awareness are beneficial strategies for the patient. Because self-management techniques are going to allow the individual to be empowered, to take this kind of invisible disability where headaches are invisible. No one knows that someone has a headache. You can't quantify someone's headache. So it adds another layer of stress for these individuals, like our chronic pain patients. So it gives them an opportunity to try and break the cycle by regaining some control, to try and maybe allow them to relax, to normalize their sleep, which can alleviate a potential trigger for them. And then overall present an opportunity for better well-being, because if you feel better, you'll eat better, you sleep better, you're less stressed, and pulling all of this together seems to minimize some of the triggers for the headaches. Particularly occupational therapists have a great opportunity in working closely with your patient from the behavioral perspective. In physical therapy, our patients talk to us a lot, so we maybe see opportunities to offer insight or suggestions not beyond our scope, but to be aware of strategies or bring to a patient's attention that they may be involved in triggers of overscheduling themselves and not sleeping well. There was a multidisciplinary program that was implemented in California for individuals with headaches, and they really promoted self-awareness and self-management through workshops, patient education, and just focusing on not only, be less stressed. Well, what does that mean? One aspect that they said is think about negative self-talk. That are you saying things to yourself like, why me? I can't take this. I don't deserve this. Whatever, if I can't get to the gym because I'm so busy, because I have to work 2 jobs, whatever it may be, that releases different chemicals into our body and has negative effects. That letting someone be aware of that, as I said, teach them to deal with just the next 5 minutes versus looking, back or forward, what they should have done differently. Help individuals identify unhelpful behaviors. What did you try that didn't work? Be aware of that. And think about on the cognitive behavioral aspect, that self-efficacy is so important for all of our patients, but particularly with this population. Self-efficacy is that sense of kind of confidence that if you put your mind to something, that you can do it, that you can take action and help yourself. That's what these patients may need, that they have found that it's associated with less migraine disability when the individual feels more empowered and feels like they have options and ideas of how to step in and control themselves. And maybe for some patients, through working with their physician or knowing exactly which type of headache they have, by knowing, this is biological, that something is happening. I'm not creating this headache. Maybe that's enough to help them get over and move ahead with management. Also, activity pacing is another beneficial strategy that we utilize for individuals who were looking at fatigue or joint strain. Consider using it for your individuals with headaches. It's that idea of self-pacing to goal of knowing what your body is capable of, both physically and mentally, and then schedule out your day so that you do not overstress it. It's just like telling someone, you know what, I can't lift 100 pounds. I may need to go get someone to help me lift that patient safely. Well, think about your schedule. If your patient in their life, maybe they need to delegate more at their job, or at their home to get other people to help themselves. That a rest break is not slacking off, that it's allowing your body to reset so that it is able to continue with the next activity. Different ways we can look at life management and strategies to help them pace and find that balance between activity and rest. In our adult populations, we can kind of get to that level of reasoning with the patients. And a lot of times those with headaches, they've tried everything already by the time we see them. And they need some of these other ideas. In our pediatric population, things present a little differently. Pediatric headaches can occur in a different way, that they evidence themselves a little bit differently. And the research says that a recurrent headache in children seems to occur in about a third of the population. Sorry, never mind, that's wrong. In about 2 to 6% of the population evidence themselves with pediatric headaches, and for those kids it tends to be reoccurrent in about a third of them. They often find that unfortunately children that present with headaches go misdiagnosed for about 1 to 3 years. There was one study that looked at children who presented with headaches to the ER. And they found that in 2013, in this one hospital, there were 450 ER visits of children complaining of headaches. And they found that the majority of those kids underwent CT scans, additional blood work. They were prescribed opiates, all of this non-standardized treatment for headaches because they were being misdiagnosed with other conditions, or the physicians just weren't really sure how to manage the headaches in those kids. That treatment ends up being similar to adults, but the first step is identifying that these kids are presenting with a true primary headache, which is not easy because they can't describe what they're feeling. They can't really describe what they're experiencing. And migraine variants do tend to present themselves in children when there is a familial history of migraines. That many adults who have migraines, if you ask them to look back on their childhood, that many of them before age 20 can say, I remember having migraines. And about 12% say that in elementary school they can remember. And I can tell you, I can remember being labeled as that dramatic attention-seeking child because I'm being wheeled out of elementary school in a wheelchair, throwing up, saying, please, shut off the lights, I want a towel over my head. That was way back in the 70s when we didn't know everything we know right now. So this is an opportunity for us, those of you in pediatrics, to be aware. And those of you who are maybe treating teenagers and even younger children for other diagnoses, you might catch something. To be aware of a migraine variant that is popping up. Because as I mentioned, it looks very different. And I will tell you, when you have the opportunity to see these occurring, it's very curious, but it does fit these presentation patterns, particularly in younger kids, 3 to 5 years. So those are your preschool, early elementary school age children, that they may present with cyclic vomiting syndrome. And the cyclic vomiting, abdominal migraine, and the paroxysmal torticollis are how migraines have been known to present in children at different ages. And the ages are not specific, it's just to give you a little idea, but there are other diagnoses to be aware of in these populations. That the cyclic vomiting in children, when they, same triggers as adults, they're not sleeping well, they're under stress, they have other illnesses maybe, that these kids have excessive vomiting, where they're vomiting over 4 times an hour for an hour or a couple of days, where if you can get the child to sleep, they're okay. But when they're awake, they're in that cyclic vomiting cycle of excessive vomiting. And they found that that is actually a migraine in those children. that when they're able to give them preventative medications to target the migraine, that these symptoms decreased for that child. And it looks different than a child who ate something that gave them GI upset, or that children who maybe has the flu, because they don't have those other symptoms that fit the diagnosis, that it truly is this episodic vomiting that then will completely resolve mysteriously. Abdominal migraines, I can tell you the first time I saw one, the pattern emerging, it was extremely curious, and many of the courses that I present are because I'm doing so much research on my own that I develop enough information. I say, you know what, other people may find this interesting too. Abdominal migraines present in more your elementary school age children, and this is where they develop spontaneously. We don't know why, but they will complain of a discomfort in their abdominal region, that they have the vasomotor symptoms. They feel nauseous. They just have uncomfortable pain in the bottom of their stomach, and nothing seems to alleviate it. They didn't eat something that aggravates them. They're not sick otherwise. They're not having GI symptoms in any other way, bowel changes. And what they're finding is that this kind of pain, awkward discomfort, very dull in the lower abdomen, is actually the presentation of a migraine. And when you look at the child, it may be their prodrome. That may be the sign for them that a more severe headache may be coming. And again, preventative medication seems to be beneficial. Paroxysmal torticollis. You're looking at the fact that they've seen this in children where there tends to be a familial history of hemiplegic migraine. And again, I have treated individuals with this where they came in with torticollis, but they no musculoskeletal techniques are alleviating. I've done, myofascial release, typical massage techniques, muscle energy, trigger point works, kinesiotaping. Just nothing is alleviating that typical torticollis. And what they're finding is that there's an alteration in the calcium channels that's causing the muscular contraction, and it's actually a migraine that's occurring. And the reason I say we tend to see it in individuals who have a familial history of the hemiplegic is because that's one of the considerations, that there's alterations in that calcium channel firing. So for these individuals, musculoskeletal interventions is not going to break that cycle, that there needs to be pharmacological management. And obviously for all of these cases, there needs to be significant communication with the physician to differentially diagnose appropriately, to make sure that another diagnosis is not missed that's more significant. They also tend to see a connection as children get older and move into their teenage years also, that those who have headaches or migraines tend to also present with different type of hyperactivity, Tourette syndrome, maybe OCD, other types of neurobehavioral comorbidities for these individuals. The thought being that both sets of diagnoses fit with some neurotransmitter dysregulation, which is why we may see those concurrent in individuals, to be aware of when we're monitoring them. Because there does also tend to be a correlation between having a primary headache disorder, say migraines, as well as anxiety and depression for those individuals. And it's a what came first is hard to say, but because there is that linkage, it's something to be aware of for those individuals. Particularly in kids, life is out of control enough for them that, being a teenager in high school and having a big test, not sleeping well, maybe they play a sport or in the band or in the chess club, whatever it may be, plus they're a teenager, life is tough, that creates a lot of stress. Maybe they're not eating well, they're not sleeping, and it can trigger a migraine. So they're in the bathroom at school worrying, am I going to start throwing up? The lights are killing me, I have this pain, and I'm at school. Or have a big test. So for these individuals, it's important to incorporate the psychological component and look at those self-efficacy skills, self-management skills, and different techniques for them. Even if it's a tension headache that the individual tends to develop, let them know they're up all night studying, head down on the laptop or on the phone, whatever it may be, that may trigger the tension headache. So empower them with techniques and strategies. Maybe it's chin tucks. Maybe it is, stress relief or stress management for them to help exacerbate an acute episode that's leading to their migraine. Teach them some relaxation techniques, or teach them some education on body positioning and recovery, or a relaxation technique they can do quietly in the bathroom, or if they're sitting at that test and they feel it coming on, some breathing techniques that they can utilize. Particularly for our adolescents, we want to look at trying to teach them how to manage, because the risk is that they're either going to push through it and lead to potentially a greater symptom, or they are going to disengage from life because they are unable to deal with the stress and the triggers and how they react. So teaching them some coping strategies. They've also found some linkages between sleep disorder and headaches in children. We know that lack of sleep or disruptive sleep can trigger migraines in adults, and for some adults, if they can get to sleep, it'll abate it. For many children, they find that with sleep, if you can induce sleep in the child and encourage healthy sleep habits, that this is going to help stabilize maybe their melatonin levels, that it may lead towards some anti-inflammatory effects of the melatonin that occur with sleeping and some of the analgesic effects. So good sleep habits can decrease the headaches in the children. Something interesting that they've also found, retrospectively looking at adults who have migraine, that around 30 to 55% of them were true sleepwalkers as children. So again, as you're talking to families, if you're working in pediatrics and you start to see some migraine variants, maybe sleepwalking is coming up, anxiety and depression, and you're treating them for head and neck pain, maybe putting the pieces together to speak back to the physician is an opportunity. Our other cohort that we need to consider is our athlete assessment. And this may be your pediatric athlete, or it could also be your adult athlete. I'd also like you to consider our veterans, anyone who may have been exposed to a mild type of head trauma. Whenever someone is at risk for a head trauma, that when we do our sideline, let's say, concussion assessment, if we have athletic trainers who are present, that we are looking at an individual who comes in, they come off the field, they say, this is the worst headache of my life. We're combining that with altered mental status. Maybe they've had a prolonged loss of consciousness, evidence of fracture, neurologic changes. Those individuals, that's a medical emergency. They need specific medical attention. There could be a subarachnoid hemorrhage. There could be other pathology that is developed from the trauma. Those individuals need to have a life-threatening pathology ruled out. Other individuals where the sideline assessment does not indicate a severe head injury, or individuals maybe you're treating them later on, if you're seeing them for that knee, hip, back injury and it's post-trauma, what we may see in those individuals are two different presentations related to headache. That the injury that they sustained, when we have a closed head injury from a concussion or a trauma, what happens is, our brain is in our head, which is an enclosed cavity. If this is our brainstem and we have the shift, the coup, counter coup, we're going to have axonal shearing of those various fibers. So because of that axonal shearing, we may have incomplete neuron transmission, and that's what is going to lead to that post-concussive syndrome that we see in individuals where they have impaired multitasking, limited cognitive endurance, maybe mood disturbance. And as part of that post-concussive syndrome, with the other, light sensitivity and things like that, we may also see a headache develop. That can happen. The other thing that can happen is because of the head injury, the individual has an increase or an exacerbation of the symptoms from whatever their other headache disorder is that they presented with previously. In many cases of individuals who have sustained a concussion, one research study looked at about 6,000 participants, so a really large cohort, and they found that at about little over 2 weeks post-injury, 11% still had a headache. By 3 months post-injury, only 7% had a headache, and it kind of continues to spontaneously dissipate. If that happens, that reaffirms that it's that new secondary headache, just part of the post-concussive syndrome for them. For other individuals, when this happens, that post-concussive type of headache, it's going to develop within the first 7 days of the injury. So those of you that are familiar, are neuro rehab people out there with the Glasgow Coma Scale, we're looking at individuals who did not have a loss of consciousness or a very short one with their injury or trauma. Their Glasgow Coma Scale, looking at their motor response, the eye opening, and the stimuli response, is placing them at over a score of 13 for their verbal, eye opening, and motor combination, puts them in a mild head injury category. Those individuals might complain of a headache within the first 7 days, along with those post-concussive symptoms that I described previously. If the headache does not develop within those first 7 days, let's say it's further out from their event, then you're considering that the headache they're presenting with is an accentuation of a previous headache disorder that they may have had, and you're going to take your symptom assessment and your management down that avenue to manage them. Typically speaking, if it is that secondary headache where it's just a consequence of the trauma, within 3 months it's going to abate. Good sleep hygiene for these individuals is important. We do tend to avoid nonsteroidal anti-inflammatories. When someone has a potential head injury, we do not want to further vasodilate the blood vessels in the brain, which may lead to risk of bleeding. So if they're telling you, yes, I'm taking some over-the-counter ibuprofen, maybe we need to ask them to stop that till they speak with their physician, unless it was prescribed, because again, we're looking at altering on a pharmacological level the vasculature that's trying to heal. That can lead to other consequences. And again, sleep tends to be beneficial for the individuals once they're out of that period where we need to have concern. If we're looking at just monitoring them post-injury, we are going to be aware of someone who is complaining of sleep disturbance, even if we're treating them somewhere else orthopedically, to communicate back to their physician if they're having sleep disturbance, because lack of sleep alters the melatonin levels, which can have a negative consequence on their pre-existing headache condition. And then prolonged exacerbation, we need to be cautious of, because they may have entered into a cycle where we are seeing an increase in their migraine or their tension headache subsequent to their head trauma, and then we need to look at kind of managing that the way we would have in isolation without the potential of the head injury. The management becomes complicated with headaches, as we're discussing, because the time needs to be spent up front in really diagnosing what type of headache it is, and because individuals could, as we're seeing, have multiple types superimposed. And a lot of times with headaches, individuals know or think they know what kind of headache they have. So this is where our interview and our symptoms assessment becomes very important, and treating our patient holistically to distinguish whether it is a symptom of another condition or the primary headache that we're managing. Our tendency as clinicians is to want to go for a musculoskeletal fix, and I get that, the orthopedist in me. However, in looking at the research and physiologically what is happening, particularly looking at migraine headaches, that our complementary therapies, our lifestyle management, and some other factors may be a more effective route in managing those particular patients. Cortisol levels, we can't tell physicians what to do. If you are working with your physician and communicating with them, maybe the patient's not progressing, you're trying to manage their migraines and you're exploring other options. If it's a receptive physician, maybe you're looking at alternative ways to manage the patient, and you use your objective findings that the patient's not progressing and what they're presenting with in terms of their symptoms to maybe try to open up a dialogue with the physician if they're open to exploring other options. In terms of management, when we talk about medications, they're not specifically looking at altering the cortisol levels as a management strategy. So you might be able to get enough information you need about the patient's migraines and ways to intervene without actually having that test result. Jennifer, I've heard related to migraines and individuals with multiple sclerosis, that is something that many participants have shared, that they're seeing a migraine pattern in individuals with multiple sclerosis. And some of it may relate to what we're going to discuss about the physiology of migraines. And again, it's another piece of your holistic management of the patient, particularly with MS. Some of the strategies of stressing, pacing for energy conservation, journaling to know exacerbations and triggers. Maybe you can use that also to look for the migraine pattern to intervene, as well as hitting on the psychological piece with that particular diagnosis of trying to be more empowering for the patient. That may help. So you might be able to, even though I may not mention multiple sclerosis specifically as we go through our next 2 hours, I think you'll be able to pull out different pieces that you'll see will be beneficial for that population. Bonnie, so looking at migraine, yes. So migraine without aura is going to be what we discussed. The individual is just going to arrive at this point of their migraine versus the individual who has an aura, that we will be talking about what that aura pattern looks like. And Bonnie, you might find it interesting when we talk about the premonitory phase. Some individuals may not realize that they're having it because it's an odd compilation of symptoms. So I encourage patients to journal to really look for their patterns because it may not be evident. Karen, so the link between stress and cephalalgia, head pain, yes. So there can be that psychological component with the tension headache that we just went through. And then stress can also be a trigger for migraines. So the key there is really taking the time to figure out, is it a tension headache or is it a migraine? Because the management is very different. And now you can see that the presentation is different of the pain pattern, unilateral versus bilateral. And when we get into aura, that'll give you some more information. Raquel, you know, in terms of having a headache with sun exposure, that can be many different factors, because remember, the headache can be the symptom of another condition or it can be a primary headache. So given that, I definitely don't have enough information to make a determination, but you might want to consider that headache can be a symptom of dehydration, hypoglycemia, so other conditions that may be related to your environmental exposure and interactions at that time. It may not be a primary headache disorder. So something to look at if you're trying to differentially diagnose yourself there. Journaling is very beneficial to try and find the patterns of the headaches. When we get back from break in another minute, I'm going to go through the different phases of migraine and the different symptoms that someone may present with that can help distinguish it from the tension headache. And yes, know that it's possible for someone to have tension and migraine headaches, because just because I have, you know, migraines doesn't mean I don't have a day at work where I have used terrible body mechanics and I didn't eat lunch, so I had soda for breakfast, lunch, and dinner, that you know, I triggered a migraine and a tension type headaches. So there are different, we really have to take the time to tease out what is going on. And we're going to take a look at that a little more. I think once I explain migraine a little bit more, it may clarify some of this for everyone. Vikram, you were asking about cerebral blood flow changes and neurobiological cause. What they're finding with migraines is previously they really just thought that it was either a vasodilation or a vasoconstriction in the cervical region, actually, that contributed to the development of the migraine. Now they're saying that it's not just the alteration in the blood flow, that neurobiologically, meaning that there's this alteration in the conduction of the nerves. There's this cortical descending misfiring, that maybe it's the calcium channels that are off, that there are microvasculature alterations that leads to cascade of effects and altered neurological impulses, that there are many different theories now on what's happening with migraine, and that they feel it's much more complex than a simple circulatory change. That's what that meant. Florence, you're asking about motion sickness in a child leading to migraines in an adult. They have not specifically said parameters related to that. We will in the next hour talk about migraine variants that present in children. So it's something to monitor children for, that if they start developing migraines, they just look different than they do in adults until they get more into their teenage years. So they haven't specifically said, it's more retrospectively, they're seeing a link there. Fran, they are finding that individuals that they've studied who have migraines, where they have seen these certain physiologic changes in the brain, that there is an increased incidence of strokes in those individuals, different types. So they have seen some references there. I actually read one study that said individuals who have the hemiplegic aura with the familial tendency, they actually have an increased incidence of, what was it? I think it was cerebellar ataxia as they age. So they are starting to see different correlations, just the research isn't there yet. It's more something to be aware of, and as soon as we come back from break, we're going to discuss being more aware for those individuals who are potentially at a greater risk of stroke because of their migraines, how to link that to a heart-healthy diet to try and minimize the factors when you can. Kendra, the ice pack for headaches. So here becomes the question. If it is a migraine, the research seems to say it shouldn't have a benefit because it's not a musculoskeletal pain spasm cycle that we're breaking into. If it is a tension type of headache, then it would make sense that if the individual is in a pain spasm cycle in the cervical spine, the ice can be decreasing the firing of the muscle spindle, inhibiting that muscle spasm, breaking into the pain spasm cycle to restore circulation, elasticity, alignment. So it may be beneficial in that way. So I would say it needs to come back to, when we look at ice pack and headache, you need to look at the type of headache to see if the ice could have a physiologic benefit. So Amber, asking about pregnancy and migraines, in terms of being treated different, pharmacological management may be different as determined by the physician, because some medications may cross the barrier for the baby. So that needs to be aware and considered by the physician. Many women, because there tends to be a hormonal trigger for some women, they may see decreased headaches when they're pregnant because their estrogen cycle has been shifted. So that is definitely something to consider, and it's not something I pulled the research on for this particular course, but it would make sense that they do need to be considered differently. Someone was asking about Botox for the cluster headaches. Most of the research that I looked at was considering the Botox for the migraine use. They can use some of the nerve blocks for cluster type of headaches. Jill, so looking at, ice versus heat, again, it gets into where what a lot of people are asking, and I apologize, I can't give a specific answer. It's just that it sounds like in all these instances, maybe a little more investigation into determining the specific type of headache and where the individual may be at in their cycle, if it is a migraine pattern, to see how those heat or cold interventions can be most beneficial. They may be helpful because it's decreasing stress and it's inducing relaxation, so maybe it's removing a trigger, as opposed to a direct physiological effect on the mechanism that's causing the headache. And that's why it's multifaceted, this management. But those are the things to consider and look at.